Falls are a symptom, a consequence of something else. Who here, let's do it by a show of hands. Hands up if you've ever fallen in your life. Yeah? Two very well balanced gentlemen here doing the painting. We've all fallen, haven't we? Hands up if you've ever been sent to a falls clinic. A lot less hands there, why not? Because your falls were an occurrence. I fell over. Your falls were not an event. Mum had a fall. Yeah? So there's a difference between an occurrence and an event, and that difference is consequences. I fell down in the garden. I was mowing the lawn, walking backwards, and I thought the rockery was at least 4 steps away. The thyme bush hasn't been the same since. I winded myself. I scratched my leg. I didn't go to hospital. I fell over. We had a gentleman come to the falls clinic. He walked backwards on his patio and fell over a plant pot. I think he was taking a picture of his family at the time. He cracked his head on the patio. He went to A&E, he got some stitches and a referral to the falls clinic. He was perfectly active. I mean, it could have been that we could have identified something to reduce his risk of falls. And we did. What? Sorry? Yes! He waited 3 months for an appointment to be told, well, do you want to move the plant pot? Because he was 80 something, but he was perfectly fit and active. He led an active lifestyle. He didn't have regular falls. It's just he'd had a fall that did have a consequence. So he got an automatic referral to the falls service. Now, when in doubt, yes, refer to your falls clinics, refer to your falls services. But actually, let's see, is it an occurrence? Is it part of life? If someone in this room sneezes, I'm not going to phone 999. Because actually, that doesn't necessarily mean there's a dangerous underlying problem. Does that make sense? Yeah? So when we ask someone, when someone comes to the falls clinic, or they turn up to your department and they say, I had a fall, we ask them, oh, what happened? And they say, I don't know. Brilliant. I don't know what happened. I was up and then I was down. Well, what's the problem? Why do you think you're falling? And they say, actually, no. It's just my balance. Well, we get legs gave way a lot, but actually, it's just my balance is the most common one we get. What is balance? Okay, we've got to work out which part of balance has gone wrong. Okay? Ultimately, your balance is your ability to take a load, so the body, the trunk, and balance it on a base, the legs. Now, we didn't have enough volunteers last time, so I'm hoping for better from this group. I'd like a few people to come up and look at these structures, which are just the same as me, 2 legs and a weighty bit on top. And see if you can get them to balance on 1 leg. Have a go, please do. It is meant to be interactive. Get you thinking about balance, okay? Okay. We see we've got a successful one. Nice, fit, healthy person, this one, isn't it? Can we see what we've done here? We've got a handstand. So this is an 80-year-old person who's doing a handstand in order to improve their balance. Yeah? Okay, that is impressive. Okay? This is an unstable hip. Okay? So that person has lifted 1 leg up and then turned their whole body sideways to be able to be it. But an unstable hip will mean that it won't balance quite so easily. Yeah? weakness. If there's a muscle weakness, then when the leg's removed, the trunk's not going to be balanced on top. And here, we've got a muscle tightness. So we can't move that across. Yeah? 3 very common problems in our aging population, yeah? And look at the difference between simple and near impossible. Thank you, ladies. Does that make sense? That's the balance that people are saying has gone wrong, but we've seen 3 completely different reasons for it going wrong. So essentially, what is our balance? Well, our balance is our ability to align our bones so that the weight goes through them properly. Yeah? If there's a problem with that, if we break a bone, if the joints are in very poor posture, well, we're going to fall. What brings the bones into alignment? What do we use to make our bones align? Muscles. We use our muscles to align our bones. So if there's a problem with the muscles, if we rupture a muscle, if we get a really bad cramp, well, we can have a fall. Now, what is it that tells the muscles what to do? What feeds the muscles? The nerves. Yeah. The nerves tell the muscles what to turn on. Now, if you've got a diabetic neuropathy, your muscles aren't going to know what to do, they're not going to do it properly. That can lead to a fall. If you end up with an injury, let's say a spinal cord injury, well, your muscles are going to let you go and not align your bones. All of those nerves are given signals by the brain, premotor cortex, motor cortex, sensory cortex, all the various parts of the brain working together, to be honest, like a really complicated spreadsheet. Yeah? So the brain's putting all of that information and working out which muscles move which bones to get us in alignment. Now, if a problem goes on in the brain, let's say we have a stroke, let's say there's a traumatic brain injury, let's say the dopamine levels are wrong, well, we can fall. Then we've got the part that actually feeds the brain. So what is it that we need to know? What does the brain need to know? It needs to know the speed and direction we are moving. It needs to know our environment and the task at hand. It needs to know our posture, our place in space. What 3 systems give that information? Vision. Vision tells us about our environment and what task we're doing.
Cerebellum.
The cerebellum's the processor, so it's what feeds into the cerebellum. Cerebellum's a big part of the brain processing.
Ears.
Vestibular system, yes. You ever sat in a train and the train beside you started moving and you thought, whoa, I'm going backwards. And then you went, no, I'm not. That was your vestibular system that told you weren't. It was your vision that told you were. So vestibular system tells us what speed we're moving and what direction we're moving in. What is the secret 6th sense?
Proprioception.
That's the one. Proprioception. Our ability to know what our posture is. Proprioception tells you when you're standing up straight. Have any of you ever had a patient? I'm going to fall forwards, and you've got the whole weight of them holding them up and stopping them going backwards. Why are they so scared of falling forwards when they're blatantly going backwards? Sorry?
What was the question?
No, it is. Go on.
Oh, because I can't tell where they are. They
Because-
think they're going forwards when they're not going.
And what system's gone wrong? Proprioception. Your 6th sense. Your ability to know where you are in space. You know when you scratch your ear? How have you any idea where your ear is? Can't see it. It's your proprioception. You don't know where your ear is, you just know where your finger is every time you've scratched it in your life. You ever seen a baby at the point where they get the finger and they go, and then they look at you and go, I'm doing that. That's proprioception. Yeah? So proprioception is that part of balance. Every fall is because those systems have failed to work well together. Could be one system has failed, could be a whole bunch of systems have got together and decided not to do all the work in the class. Does that make sense? Yeah? That's balance. So when a patient says to me, it's my balance, I do my little Wallace and Gromit handshake, because balance is no one thing. And to think it is really doesn't help them. So when we start questioning them about falls, number of falls, how many falls have occurred? How often are they occurring? What's the frequency they're happening with? Are they episodic? Now, I just said we'll see people 6 months after they've had a fall. Have they had 3 or 4 falls in a small period of time? We've had people that have had little groups of falls because they had a UTI. That makes sense. What about someone who's had a little group of falls because they lost their life partner and they were grieving and that affected their balance? Yeah? So look for those little pockets of falls. We've even had people that have come in and they've had 2 episodes where they've had completely different falls, but they've actually had something that was going on at the time, not something really that's going on now. Where are they indoors? Where are they outdoors? Where are they in the kitchen? So just getting that little picture of where the falls have been happening, how often they are, how many they are. I will generally ask the last 12 months. And so often people will say, well, 3 years ago. Like, well, won't worry about that. So it's really important that you spend a bit of time keeping the patient on track to get that idea. The big question, were any of them syncopal? We all know what syncope is, yes? Okay. Falls are in pretty much one of 2 categories. Syncopal, non-syncopal. When they're syncopal, well, I'll be honest, I don't do much at all. That's over to the medical teams. Because if they're syncopal, we are looking at cardiac problems, cerebral problems, autonomic problems. Did you all see the poster outside about the pacemaker? Yeah. News to me. News to me. But actually, it wasn't news to the consultants I work with, because I've now got a bit of a deeper insight into what they're looking at when a patient has a pacemaker and has had syncope. So, syncopal falls. If the answer's no, well, I've gone straight to vertigo, because when we're talking about syncope, we also want to know what's preceding the falls. And if the answer is dizziness, then we've got to think about vertigo. Because if it's vertigo, you know, the wonderful BPPV, anyone know what it stands for? Benign, paroxysmal, positional vertigo. Positional is the important part, because it will be recurrent. It will be when they put their head on the pillow every night, because it's a problem with the vestibular system. If it's BPPV, it will be reproducible, okay, because it's all to do with the canals in the vestibular system, the autoconia, okay. It could be there's an element of vestibular hypofunction, but if it's true vertigo, that is eminently treatable. It really is. I've known people that have had vertigo for months and months and months. They went and saw someone, had the Epleys done, and the next day they were fine. So if it's vertigo, let's find out, let's get them to the right place. If it is vertigo, and if it's not vertigo, then we are really looking at the circumstances of the fall. How many parts of the body can you land on if you fall in an open space? Let's go through them. What parts of the body can you land on? Bottom, yes. Knees. Sorry? Hips. Wrists. Face, the superhero mask. Black eye zone. Anything else? Head, the back of the head. So we've got the face, the back of the head. One other.
Shoulder.
Upper arm. Now anywhere along the shoulder and the upper arm. Well, let's just think about that, because the person has already told us they don't know how they fell. What did you hurt? I hurt my arm. What way did they fall? To the side. I hurt my hip. To the See? I hurt my wrists or my face or my knees. Forward. Well, I landed on my bum, cracked the back of my head. Backwards. So just by finding that part out, we can begin to get an idea, we can begin to see the fall. Wouldn't you love to have a video camera on every fall one of your patients has? Yeah? Well, that is the first part. Think about what part did they land on. Okay? It can be two parts they give. So I've had people say I landed on my knee and my arm, which kind of means that they were twisting at the time. But paint that picture for yourself. Try and get that image of how the body went down. If there's an obstacle in the way, if there's a table, a chair, a radiator, it can be any part of the body. Yeah? If someone falls and they've hurt their ribs in an open space, what do we think's happened? The elbow. Yeah. So quite often it'll be the ribs that are hurt, that are really hurt, but it'll be the elbow that dug into them. Does that make sense? So yes, people will injure their ribs from a fall in an open space, and you'll go, I was at the falls assessment, he never said ribs. It's actually because that's gone into them. If it's an object, it's the only part of the body that it hits. Now I think of falls in four ways: trips, slips, twists, and overbalancing. What is a trip? And you're not allowed to say 2 weeks in Spain. Sorry?
Uneven pavements.
Uneven pavements? No, I wouldn't have that as a trip. It'll come into this categorisation. Fall over something. It's interesting, that's the way we think of it, catching your foot on something, yeah? No. Watch, I'm going to catch my foot on the carpet there. My foot is caught. Why am I not falling?
The leg steady.
Because my weight's on my leg. So a trip is when we go to put our weight on a foot and it doesn't turn up. Yeah? So we've committed our body weight and then caught the foot. Our momentum has taken the body weight on, the foot didn't turn up. If I went to sit down on a chair and someone thought I'm going to have a bit of a giggle here, down I go. Because I've committed my body weight to a surface which is not there. Does that make sense? So that is what I think of as a trip. Because I spent a while thinking, what is a trip? It's not the catching of the foot, it's the committing of the body weight. So, you know, we've seen, perhaps you've seen Tai Chi walking, where they put the foot forward first, then move the body weight. You cannot trip if you do this. So if we can only get all the elderly people in the world
Did you touch it?
trips will end. Slips. What's a slip?
Oh, don't say that. Because I was convinced a trip was tripping over something, so that's new. That's good.
Well, yeah, that's where the name comes
Yes,
from.
yeah.
But actually, if we look at the mechanics of it, that's where I categorise my falls.
So a slip on a wet surface, or
On a surface.
yeah, where you've committed your weight.
On a paving. Oh, you're wonderful.
Uh-huh.
Where you've committed your weight. A surface you've committed your weight to behaves in an unexpected manner. My favourite example of a slip, my son, now very large and teenage, when he was younger saw some wonderful ice on the pavement. Off he went. He was balanced. He used his brain, his balance, to keep himself balanced, and along he went on the ice. Didn't notice the number 26 had cleared the path. So his slip wasn't because of the ice, but the lack of it. So the surface didn't do what he had expected, what he had prepared his brain for. Can we all walk on grass? Can we all walk on concrete? Can we all walk on gravel? Can we all walk on water? Well, we can walk on water, just got to be very, 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 very shallow. But when we're walking on different surfaces, the brain goes from one movement pattern to the next, just like that. Have you ever seen someone with Parkinson's freeze? Yeah? That's because their brain can't move from one movement pattern to the other like that. So they come up to a new surface, changing the carpet, changing something like that. You're okay. Changing the surface they're standing on, and they need to take that next step to get back into the walking. Does that make sense? So the paving slab, you stand on the paving slab, it tilts, that would be a slip. Yeah? So if you were meaning the paving slab was up, then okay, we could consider that a trip. And a lot of people blame the councils for the paving slabs. And I do like to point out to them, you are the most mobile of all the creatures on the planet in half a centimetre. We're going to blame that on the council because the earth doesn't move, does it? We could spend all our tax money just making sure the pavements are level every single day. Twists. Well, a twist is when we're taking the axis of the body, okay, the planes of the body as well, and we get them a bit confuddled. So whenever we're twisting the body like this, now that's going to give us a fall in two ways. One, it's actually really difficult to understand where to put the body weight. So if I'm going to go to the right, and I'm about to walk off to the right, which way is my balance going to go first? Left. See that? Yeah. So if I got my weight on this leg because I don't like this knee, it's got a bit of arthritis, and I twist to that side, I'm going. Does that make sense? The knee does not like to be twisted. If you twist the knee, it's going to want to give way. Okay? So twists, very common way of causing falls. Overbalancing. Okay, so let's just think about an aging spine. Yeah. Now, I can't straighten up. I've got an older Stefan. If I want to close the curtains, if I want to reach down to the sockets, I'm going. So the overbalancing is literally when we are not getting our posture right. So that person I was talking about before is leaning heavily back but thinking they're falling forward. They're going to have overbalancing backwards. Okay. Do you have overbalancing falls? I would put money that each of you have many of them every day. Let me show you. Did I sit down or did I fall down into a chair? Let myself fall down into a chair. If I was sitting down, I'd be able to go all the way down and back up. It wouldn't matter if someone pulled the chair out. Does that make sense? So we're teaching ourselves quite regularly to fall. We're overbalancing backwards and going, that's all right, the chair's there. I will try and fit all the falls that are not vertical, that are not syncopal, into those kind of four categories. I'll be honest, they're kind of my own, but it helps me paint that picture of what actually happens. Right. Medication. Now, I'll be honest, this isn't my area as a physiotherapist. This is what the consultants will look at. So I've got a wonderful sheet with high risk, moderate risk, and low risk medications on it. Do you know what the main risk is? How many medications do you need to take to be at risk? 4. Okay, I've put the high risk ones up on the slide and the flow chart is there as well. You can take that at the end. High risks: antidepressants, antipsychotics, antimuscarinics, benzodiazepines, hypnotics, dopaminergic drugs. Moderate risks: the ACE inhibitors, alpha blockers, antiarrhythmics, antiepileptics, antihistamines, beta blockers, diuretics, opiates. I have to say, when I showed this to my wife, she went, antihistamines? I thought, I'd never thought about antihistamines. Calcium channel blockers, nitrates, oral antidiabetics, and proton pump inhibitors. So those are the medications where if you are on one of them, there could be a risk of falls. But if you're on 4 medications, there's a definite risk of falls. Systems check: sleep, continence, vision, hearing, mood, pulmonary systems, skeletal system, nutrition. Each one of itself not a high risk. But if you've got somebody who is sleeping badly, not eating well, and has incontinence, you've got a recipe for a fall. Yeah? So it's a good place to do a systems check, having a look round the whole body. Falls, I tend to think of as a bit of an MOT stop. Let's have a look at the whole thing. existing pathologies. Now, not a limited list. I've just put up the ones that quite often we see are related to falls. The interesting part here is that sometimes the fall is the first consequence. Yeah? Someone had a fall. Why? Actually, they did a stroke or a TIA. That's what caused the fall. Someone caught their foot because they've got a foot drop. Well, actually, that can be the first sign of MS for a lot of people. Or the first sign of a diabetic peripheral neuropathy. So asking about existing conditions they have as well. A lot of people might have an existing condition, it'll be on the paperwork, but they're not actually being actively reviewed for it. And maybe it's time to send them back to the appropriate consultants. A lot of time, our consultants will start to deal with some of these difficulties. They'll start to do something along the neurology, start to do something for the polymyalgia or the diabetes, and then refer back to the GP. This is where we come in, the therapists, as in lifestyle. Adaptation and habituation. Okay, now, complete plagiarism. I'm just going to use this wonderful part of the mural that's being developed behind me. We've all seen this before. Yeah? Okay, so Darwin's pattern of evolution. What is it that allows us to walk on two legs? What anatomical part, what posture allows us to walk on two legs successfully for 26 miles? What's causing that curve? No, go between the two of those. The pelvis. Okay? So, as we evolved, the pelvis changed position and we stood upright. As we sat down, the pelvis changed position and old age suddenly looked like we were devolving. It's not old age. I want you just to sit, pop your feet flat on the floor and put your hands out in front of you and then look, are your hands just about the same level as your knees? Can you see you've gone back to being in a posture good for all fours? Not for two legs. Okay, pop your hands down. So let's think about your patient. 8 hours in bed. Let's be really nice and say that they are active on their feet for 4 hours a day. That's 12 hours sitting in the chair, changing their posture. Do you all know what shoe size you are? Yeah? Fair to say? Would any of you wear a shoe that was 2 sizes too small? No? Would you wear a shoe that was 2 sizes too big? No. What size chair should you sit in for your body dimensions? Or are you going to change your pelvic and spinal posture to fit the chairs that are around you, that you choose for your house, that go with the decor? Yeah? But that's where your balance sits, is in the pelvis, and we're giving it up to get better at sitting in chairs. Do children like sitting still in chairs? No, because their bodies are screaming at them, I'm not designed for this. Those of you that are sitting with your legs crossed, why are you crossing your legs? To protect your spine. Your spine's screaming out, going, I want a lordosis, I want a curve at the bottom, stop pushing me the wrong way. That's why we do it. We all know crossing your legs is bad for you, but we do it because it protects the spine. So that is what we call adaptation and habituation to the chairs. And if you've got someone sitting in a chair all day long, that's going to affect their balance. What are their activity levels? Do they do specific exercises to overcome the effects of the chair? What's the environment like at home? Is it higgledy-piggledy? I know one person, their falls risk was the fact they live in clutter. So what do you do to remove the falls risk? Sorry? No, they don't want you to. It's their choice. It's a real difficult situation. They want to live in the clutter. So we've got to ask about the environment. Do they have stairs? Do they have steps? Are they putting themselves at higher risk? Okay. Do they drink to excess? Long-term effects of alcohol, not known by everybody. Short-term effects, most of us know. Support. Have they got a wonderfully supportive family that are getting them out, keeping them active? Have they got a family that are telling them to sit in the chair and not move in case they fall? If you go into a ward full of people that have fallen, what are we going to say when someone stands up? Sit down. The diabetic who had a hypoglycemic attack went into hospital and we said, no, don't take insulin. Would that be irresponsible? Yeah. So a faller whose balance is poor, who's deconditioned, comes into hospital and we say, decondition more, get worse. But that's safety, isn't it? I know of a lot of people that have gone into hospital, they weren't falling, they've come out deconditioned. Cognition, risk awareness. Are they aware of the risks they're putting themselves at? Yeah? Are they overly risk averse? Are they worrying about every step they take? The anxious patient. Okay, stand up for me. Everybody stand up. Okay. I got the 5 minutes now, so I'm speeding up slightly. We're all going to become slightly elderly, slightly anxious. Feet wider apart. Pull the knees in. Pull your elbows into your side. And tense your tummy muscles. Okay? Take a step. Yeah, feel that. None of you have got weakness. Have a seat again. None of you have got weakness. None of you particularly got balance problems, to my knowledge. And yet, all of you had difficulty taking a step. That's what anxiety can do. Okay? So the anxious patient, the one that worries about falling all the time. It's a wonderful system, actually. I'm going to fall, I'm going to fall, I'm going to fall. Say it long enough, it will be true. So, for those of us that like to be right all the time, just say it. But it does not help prevent it. Then we get the physical assessment. Power, stability, compensation strategies. What do I mean by compensation strategies? If we want to stand up, if we want a patient to stand up, we tell them to put their hands on the arms of the chair. But then they're using their spinal muscles instead of their abdominal muscles. So we've got them doing that to get up from a chair. Yeah? We're getting people to stand up like that. So, can I ask you just to have a seat in this chair for me a second? Okay? And I want you, without moving the chairs and without bending your head forward, to stand up. Not to bend your head forward. Okay? So keep your body upright and stand up. See her coming forward. If we put the arms on the hands on the arms of the chair, then that can do all the work for us when we keep ourselves upright. Does that make sense? So we're looking at those compensation strategies. Thank you. Then we've got to look at posture, particularly the pelvic posture. We've got to look at the coordination, and of course we look at gait. Are you an expert at looking at gait? If you see someone and they are missing a part of their gait, you will say that they are limping. Yeah? You ever walk down the street? Oh, he's got a limp. That's you automatically noticing some component of gait isn't working right. Okay? That doesn't mean you know which part of gait necessarily, but it means that you can see, well, that's not quite right. So looking at the anxiety, when someone's got that anxiety shuffle, we don't say they're limping, do we? Because actually it's not a component of gait that's missing, it's a whole range of different things. I have abbreviated slightly because I got the call there, but has all of that made sense? Yeah? We want you in A&E. If someone's got a problem with gait, posture, power or balance, get them to a physiotherapist. If someone has problems with their environment, with the activities they do on a daily basis, with their transfers, get them to an occupational therapist or get them to social services via the GP. If they've got a problem that requires neurological input, cardiac input, orthopedic input, continence input, memory clinic, balance clinic, vestibular system, optometry, audiology, get that referral in. Because what we're seeing is a spate of, we'll get them to Falls Clinic. Wonderful, we will go in deeper. But actually, if there's a couple of simple bits there, that could be addressed from that initial contact, then it's worth it, isn't it? So that's pretty much the assessment part. We want people to be safe, we want them to be independent. The bit in the middle is what we need to keep them. Yeah? And that's where the therapies teams, our program, 6 weeks, 2.5 hours a week, has an awful lot of therapy. Okay. Any questions?
Can I just ask, you know, with the symptom, the diagnosis like Parkinson's, stroke, why isn't dementia in there?
No. Like I said, that's not a definitive list.
Oh right, okay.
That's just the ones we
before
come
it
across
wasn't.
quite often. Where I would put dementia would be under the risk awareness, because dementia's effect on falls mainly comes from that reduced risk awareness part. You know, I've seen a lot of people where perhaps Alzheimer's does have physical manifestations as well, but mostly the dementia part is because they've got a poor risk awareness. So that would be where I'd look at that.